Thanks for joining me here. This is Backwoods Harm Reduction, and my name is James Wilson. I work for Plumas County Public Health Agency. I was born and raised in Plumas County and went away for college, went to UC Berkeley, stayed in the Bay Area for a while, and moved back about 8 years ago after I started my career, and I'm really stoked to be living back in the same spot that I grew up in and get to share the same sort of adventures with my kids that I'm raising now too. So I kind of set up this presentation to give you, first off, a sense of Plumas County, since that's where I operate and that's what I know, and describe what our health department harm reduction program looks like. And then I really wanted to go into the theme of just exploring what's working and what needs to change, because since we launched our program, we've changed pretty dramatically. We've made a lot of mistakes, and so I want to kind of get into those. And then also describe some of the solutions and wraparounds that we've been able to come up with. So to start off our about Plumas County and describe that, I want to just first off do a land recognition that this Plumas County is the ancestral homelands of the Mountain Maidu people. It's very beautiful, very mountainous. I know there's a lot of people here from California, and there's a lot of, California is a huge state. It's Northern California is like up, well, where I live is up in the Sierra Nevada mountains, and it's very rural, very remote. It's our county alone is about the size of Delaware, but there is only about 19,000 people that live here. Being up in the mountains, there's a lot of geographic barriers. So you can see on the left shows like the 5 main towns that make up Plumas County, and most of them are in these mountain valleys. So to be able to get from Quincy to Greenville, for example, is it takes a lot longer than it should, just because you have to go around a mountain, down a canyon, and then up another canyon, and then you pop into this valley. That's kind of the same thing with all of these. And so when we're doing services, we also have to kind of navigate through the terrain of our county. The biggest town is Quincy. That's where I live, and that is a town of 5,500 people. The whole county is very red. It's predominantly voted for Republican parties last year. Like a lot of other small counties, our county has been decreasing in population quite a bit. Our main source of industry was logging and sawmills, and unfortunately, a lot of them closed down about 20 years ago, and so a lot of people ended up fleeing the county searching for work. So you can see a big decrease in population. That's also kind of resulted in a lot more poverty as well. Yeah, and I think also going in line with that poverty, the suicide rate is quite a bit higher in Plumas County than it is in the rest of California, 113% higher. And there's also a lot of drug use in Plumas County. This is some data that was collected between 2009 and 2013, but we had 6 times the rate of overdose deaths than in California. And at the time, it was mainly kind of pointed to be more so due to pharmaceuticals, but as a lot of the CDC guidelines on prescribing came out, a lot of people were unfortunately just like cut off their medications. And in the last several years, we've seen a big spike in heroin use as well. So everything for us here at our health department kind of came into focus around 2015. It was very obvious that there was like community level trauma that was going on. We were losing about 15 community members every year, and with a community our size, that was extremely substantial. So it was at the time linked very much so with the high prescription opioid rates that were going out. We had quite a bit higher than the state as well, and we had 0 access to naloxone in our county and 0 access to MAT of any kind. There was no doctors prescribing buprenorphine. The closest methadone clinic was, in a city that's in a different county. It would take people 3 hours of travel every day if they wanted to get hooked up with a methadone clinic. And it just wasn't an option, really. And there was no other agencies that were doing any sort of drug-related harm reduction work at all. There's also, in a county our size, a whole lot of stigma, and I'll be going a lot into that here in a little bit. So what we decided to do is we formed a coalition to try to reduce the prescription misuse in the county, and that kind of got us kicked off on all of this. We formed a 4-county coalition. None of our counties around us or us really had the capacity to full on take on this problem. And so we joined forces with Sierra, Lassen, and Modoc County. And at the time, our efforts were mainly aimed towards prescription reduction, trying to get some sort of MAT program started, and trying to get some sort of naloxone distribution going on. Well, around that same time, the CDC came out with their vulnerability assessment that was basically linking the counties around the U.S. to see which ones have a lot of similarities to Scott County, Indiana, which had a big HIV and Hep C outbreak. Plumas County and Lake County in California, both very rural and kind of separated from any major city. Both of them were identified as highly vulnerable. So with knowing that, we knew that we had to do something, and we began the process of getting our community ready for a syringe service program. That kind of got us linked to harm reduction. What you're seeing here is the logo that we came up with. This is also kind of our mascot. We like to lovingly refer to him as Pokey the Bear. He's holding a syringe in one hand and he's got his naloxone in the other. And so we started to do all the work that we needed to get a syringe service program certified. And this is what the syringe service in Plumas County looks like. So we first off, before we started our program, we had a couple of focus groups with people who inject drugs to find out how they would best be willing to access a program. And they said they wouldn't come to our health department. They'd prefer to have it in the wellness centers that are around the county. And so we set up 3 fixed sites, and we based it off of the capacity that we had at the time. We were offering services twice a month for 2 hours, so in each town, basically, or in the 3 main towns. We weren't able to do it in Greenville and Graygle, unfortunately. So we started out every first and third Tuesday. We do it in Quincy, every first and third Wednesday in Portola, every first and third Thursday in Chester, and then we reserve first and third Fridays for mobile deliveries. We offered syringe access and disposal, and I also got to say, it's a joke. This isn't really what our program looks like. I just like showing people that just to see like what it actually could look like if we're doing it. We were able to upgrade and get a better van. So this is the van that we were using for health outreach and just like in outreach in general. On the right is just a picture of our storeroom, and on the left is, or sorry, the bottom is what it looks like when we were setting up our sites at the different wellness centers. So we offer a whole variety of different things in addition to syringes. A lot of safer injection supplies, condom distribution, naloxone distribution, Hep C, HIV testing and counseling, and referrals to STD treatment, Hep A, B vaccine, STI screening, and housing services. So we spent a lot of time fretting about like what this program is going to look like. Wanted to get it right on the first try, and the first day we finally open, and a mother walks in and with her 2 kids, and she has been holding on to these 2 needles for a long time that they use to vaccinate their horses, and she didn't know what to do with them, so she dropped them in. We sat around for the rest of the day waiting for more people to come, not knowing what to expect, and at the very end of the day, we had our very first participant, and it was somebody that was basically referred to by one of our co-workers who came to pick up supplies, do secondary exchange. So the first 3 months were extremely brutal. We didn't know what was going on, but after that first participant in the first day, we didn't have any other people access our services for almost the whole 3 months. At the end of the first 3 months, we had 2 more participants come in and get some supplies from us. And we had a lot of questions going on in our agency. We knew that the community was aware of the program. We did a pretty good job of advertising it and letting them know about it. We were very transparent, and we'd heard from secondary sources that our community that injects drugs knew about it. but they just weren't showing up. And our agency, some of the leadership in our agency really started questioning about whether or not this program was worth all the time and effort that we were putting into it. A lot of the staff that were doing it on the team as well thought that it was kind of a waste of their time. We all had different hats that we were wearing, and it was a lot of work. Well, I do want to let you know that our program today looks a lot different than that. 2020 numbers, just for example, last year we had 475 individual interactions and distributed over 73, close to 74,000 syringes, and collected about 2,500 more than we distributed. We also distributed a ton of naloxone and got about 30 overdose reversals reported to us, which for a county of our size is, I feel like, pretty significant. So I want to go into the rest of this this presentation and talk about all the different challenges that we faced and what we did to basically adapt to our community and find out and change our program so that it actually met their needs and they're able to access the program. The challenges that I really want to touch on are transportation, stigma, low capacity and time, lack of trust, law enforcement interference, challenging outreach, community opposition, and COVID-19. I should point out that some of these challenges we haven't really come up with a innovative solution to, but I feel like it's still worth mentioning just because it is something that's really real in our rural frontier type of area. So to introduce these different challenges, I'd like to get into this model that was developed by David Showalter. He's in the Department of Sociology at University of California at Berkeley. And it's the model of social morphology and social structure. And it basically compares urban areas and small and remote towns and how they really differ and how our social structures really differ in those as well. The first one is really simple, transportation. Our demographic distribution just like is very, very different in an urban setting compared to a small and remote town. In urban areas, it's large and dense populations that kind of reside in bounded neighborhoods, where in remote towns like in Plumas County, it's really smaller populations in compact settlements or just really sparse scatterings, which we have a lot of both of those. Picture on the left shows Plumas County, and I just wanted to show this because as far as transportation, when we're talking about our challenges, we're not only referring to our own challenges, but we're also referring to the challenges of our participants. So Plumas County is located away from any major highway. We're in between 395 and 5 and 99, basically. And so for our participants to get drugs, they have to go out of the county for them. A lot of the ones on the eastern side of the county go to Reno. A lot of the ones on the western side of the county go to Chico or Sacramento, generally. It takes a long time, a lot of gas, and a lot of times when they're there getting their drugs from Reno, it just makes sense for them to also stop by Northern Nevada Hopes, which is the Syringe Service program there, and get their supplies as well. So we do miss a good number of people that are, going off to other counties. It also presents a real big problem for us because we also have to do quite a bit of traveling with our deliveries. On the right is a picture of me and the snowpack that hit a couple years ago. So the several days before that picture was taken, we were pretty much stranded. We were an island. We couldn't really get anywhere because the roads were closed off. Big snowfalls and rock slides and just like icy weather conditions are a very regular occurrence in Plumas County. So when we're talking about doing mobile deliveries, it also presents quite a bit of a problem for us to get there or for participants to come to Quincy, where we eventually opened up our hours so that anyone could come 5 days a week. So to be able to combat that, one of the things workarounds that we came up with is on the bottom, you could see a photo of just some different bags. We got 28 is out of the picture, and then there's 29, 30, 31. So these are like to-go bags that we developed and we put in the wellness centers around there. We were also able to expand our authorization to distribute syringes thanks to the CDPH granting us expanded authorization. so that anyone was able to go to their local wellness center if they couldn't come into Quincy and pick up a to-go bag, which, you know, our program that we normally operate is needs-based, but these would at least tie them over with 30 syringes, a sharps container, and some injection supply kits that have clean water, cookers, cottons, and alcohol prep pads and Band-Aids. So this would hold them over until we were able to actually get to them. And this has been a pretty popular item that people have been getting. Okay, the next one that I want to get into is Stigma. Going back to the social morphology and social structure model, social networks and interactions. In urban areas, it's pretty much anonymity with virtually all neighbors and in public places. But in small and remote towns here, it's dense, multiplex, and there's long-standing ties among residents. My wife always jokes with me about how she hates going to the grocery store with me because if I go in to get milk, it takes me 45 minutes because you run into people that you know, and when you have face-to-face interactions, it's almost like a social requirement to stop and talk. So this is extremely difficult for a lot of people to access services because they know the people that are giving them. A lot of people, you know, that work in our offices or at the behavioral health office, which is connected to our building, a lot of people don't want to show up here for services because they're really, you know, afraid that they're going to get judged, that they're going to get looked at and scorned upon, and that they'll get recognized, basically. So another big thing that we came across was the picture on the left shows us, and we set up a HIV testing stand. This was during a health fair, and we had our big van there that was kind of at that point the community had branded it as, this is the Syringe Service van, and if you get caught anywhere near it, people are going to know what you're doing. So nobody was asking for deliveries at first because they didn't want this big old beastly van to drive up and like all their neighbors to be like, oh, that's the syringe van. So we ended up basically having to start looking at deliveries in the same way that we would a drug deal. So we talk with participants and we find out where would be the most convenient location for us to do a drop-off. We change out cars. We go in a very discreet car generally, and we'll meet them wherever they feel comfortable, and we'll do the exchange. That has really increased our number of deliveries and participation in our program significantly just by not utilizing the van. It's a bummer because the van's really handy when it comes to storage and all that, but it's really about just what's going to work. Okay, going on to the picture on the right. This is our staff member, Christopher, and he is getting ready to go out to one of our local trailer parks that is a very, very dense population. They're all kind of lined up next to each other, and on sunny days, pretty much everyone that lives in the trailer park will be outside. So he's going to go do a delivery, and he's probably going to get a lot of eyes on him from neighbors. And so what he's doing is, if you look closely at the top of the bag, you can see some top ramen and some chips popping out. So we store all the supplies at the bottom, and then we fill up the top just with basically some sort of food. So it looks like we're doing a food delivery. This has been a big hit with our participants because not only do they get their supplies that they need, but they get some yummy snacks too. Next area I want to get into is talking about low capacity and time. So this is the original staff that we had with the program, Nicole, Megan, myself, and Barb's. And all the folks that are on the program wear multiple hats. So we're all also involved in other programs with our health department. I'm like part of 6 different programs myself, and so it was really difficult to actually get this program started because we were all just running around like chickens with our heads off, not, you know, trying to just get as much done as we could. So another area of low capacity and time, before I get into like what's actually helped out with this, is I just wanted to give an example about how having low capacity can really affect a lot in a small community. So this is a picture of the local doctor that we were prescribing PrEP to, or the local doctor that was prescribing PrEP. She got into a car accident about it's been almost 2.5 years ago. And unfortunately, fortunately, she's fine. She lived through it. But, you know, I mean, we do have these canyons that we have to wind around through. And so she went off a cliff and crashed into the creek. And she was out of commission for about a year and a half. And because she was the only doctor in our area prescribing PrEP, we had to completely shift it so that if anyone was interested, we would get them to basically go to PlushCare to be able to get an online app where they can get it. But this is an example of like if this had happened to, for a while, for about a year and a half, we only had one doctor that was prescribing buprenorphine. If that had happened to him, then a lot of patients would have just been instantly no longer able to do that. So what has really helped us is the California Harm Reduction Initiative funding that came through CDPH, and it was a game changer. We also have partnered with CDPH to get some funding for a Hep C navigator, and both those funding sources have like actually allowed us to hire people that are dedicated to the harm reduction program. So their low capacity has just like increased substantially. That also allowed us to really increase the number of hours. We were able to open it up 5 days a week at our location here in Quincy, and it was just amazing. We do have some applications in for other grants, but hopefully just as far as to really keep the capacity at what it is right now, eventually in the future, it would be amazing if there was some sort of sustainable funding that was tied to legislation that would really allow us to continue this program that is desperately needed by our community. Next bit I want to get into is lack of trust. And I think that this was one of the main reasons that we only got 3 participants at first. The social morphology and social structure model shows that as far as social organization in urban areas, it really relies on impersonal norms and expectations. But in small and remote towns, it relies on personal familiarity and trust. It's seen in so many different ways here that people they won't access a program or they won't buy into something that could be possibly controversial unless it comes from someone that is already trusted in the community. So I want to point out, like when we did hire staff, we made it a priority to hire people that were part of the community that uses drugs in Plumas County. This is our staff member, Chris DeHart. He was also a game changer. The people that use drugs in our community trust him because they've either used with him at some point or they have spent time in jail with him. He's now on a MAP program, and he has been really integral to also helping people navigate what that looks like. And that really just like really helped out tremendously. And it's basically our policy now to only hire people with lived experience. Another point I want to touch on is law enforcement interference and how that differs in a small rural area compared to an urban area. In urban areas, authorities are typically strangers to their constituents and clientele. And unfortunately, we don't have that luxury here in Plumas County, where authorities basically grow up with and live alongside the people that they regulate. A lot of people that use drugs become targets because they are known by the people that they went to school with that are now law enforcement. And anytime that they sneak out of the house or go to the store or anything like that, they're basically watched by any time that a law enforcement officer sees them. And so it's a real difficulty for them to also go out and get services, mainly out of the fear of being watched. We were really, really afraid of just law enforcement being basically standing right outside our program before we opened up. And then this next slide is a photo of the very first day that we started operating. So it's not what you think. We started operating, and about 20 minutes into our program, this was one of our main fears, is like no one's going to access our program if there's a cop out front. And so 20 minutes into our program, somebody had driven and like actually ran into a wall into a building right on Main Street. And so all these cops just like showed up right like across the street from where our program was. So that also could have had something to do with it. But luckily, we do have, for the most part, a pretty good relationship with our law enforcement here. They're not too keen on us distributing pipes, but other than that, they seem to be supportive of the program. Challenging outreach. So there's not really a visible homeless population in Plumas County. It gets really too cold, so we don't have any encampments, like mass encampments where people gather or they're able to like be together. So there are some, definitely there's a homeless population, but most of them are like sleeping on a friend's couch. Some of them go out into the woods and they'll pitch a tent, something like that, or make their own little cabin. So it makes conducting outreach pretty challenging. One of the workarounds that we have done that I wanted to show on the picture on the right is something that my mother used to drag me to a lot when I was a kid. It's a Tupperware party. And so we were thinking about how can we actually get outreach out there and utilize, some of the folks that do trust us to really spread the word to other folks. And the idea of a Tupperware party came to mind. One person would host the Tupperware party, would have all the different Tupperware, and then their friends would come over and look at the Tupperware and see all the different great products that were offered. So we kind of copied that model. We would find participants that were willing and we would pay them to host a Tupperware party. So they'd get all our different supplies and they would invite their friends over and their friends would actually see all the different supplies that we had available and buy into the program, and then also get we'd get vouched for by this participant, and that also helped create a lot of trust. Some other ways that we've done outreach, a lot of it is just like really it takes time. On the right is a picture of me and one of our other staff that are sitting outside the Allegheny Supply Company store. So this is a town where there's about 100 people that live in the town. It's very, very isolated. It's on the level of Appalachian like towns out there, and it's very poverty stricken, and nobody will trust you unless you're part of that community. So one of our staff has been going out there once a month just to make themselves known, just to kind of become a part of the community and eventually get in there. The other bit is the picture on the left is our Christmas card that we gave out to participants. So there's 5 of us that are on the staff right now, and some of our participants would only feel comfortable getting supplies from Nicole. Some of them would only feel comfortable getting supplies from Chris. Some would only feel comfortable getting supplies from me. So to be able to open it up, we wanted to just like let people know that we are a team, we're all trustworthy. And it's really helped since, in the last few months, people have felt comfortable going to any of us and getting supplies. So that's helped out a lot. Community opposition, we have been thankful enough where we haven't had a ton of opposition from the community, but we have had some. The tactic that we've always taken with this is we really just try to show what the authoritative voice is. To the left is the CDC's fact sheet about syringe service programs. We've given that out quite a bit. Excuse me. On the right is a post that we put out on Facebook. So somebody had on Facebook, one of the community forums said, I heard that Plumas County Public Health has a safe injection van where they drive around and people can come in and get supervised while they inject. Be a great idea, but unfortunately it's not legal right now. So to basically combat that, instead of just getting into a tit for tat argument with them, we went to our official page, Plumas Health and Wellness, and we showed, hey, this is great. This Academy of Sciences just released a report where they named our program as one of the ones that have been able to link Hep C treatment and outreach along with the opioid response. And so I feel like just having a rebuttal from an authoritative sort of point of view has really helped us and has helped us avoid a lot of community opposition. The other bit, so the 2 middle pictures are basically to demonstrate that we've tried to be as transparent as possible. We have in the middle is our director, our public health director, Andrew Woodruff, and he's talking with the rest of our Northern Sierra Opioid Safety Coalition, letting them know far in advance about our plans to open up a syringe service program. The bottom is an article that we released to our local newspaper, letting people know that public comment was available. So if they were not able to voice their opinions when it was readily made available, then that's kind of on them at that point. The other bit that we did to combat community opposition is we wanted to find out how much opposition actually is out there. So we sent out 1,600 surveys to our 4-county region as part of our Opioid Safety Coalition, and we asked numerous questions regarding different policies that are available that could be implemented in the counties. This one is asking about, do you strongly support, not support, or strongly not support syringe service programs? And overwhelmingly, in all 4 counties, the support was huge. In Plumas County, 79% of our community support it, with 50% strongly supporting it. There was only 21% that didn't support it, and only 3% that strongly did not support it. So this is a great way. I mean, when you think about it, there may be some opposition, but it's really from a few people, and they just like to be loud, basically. But it's good to know that the majority of the community have our backs. The last bit that we are dealing with is COVID-19. We're still in the midst of it. We were able to expand our authorization to include Monday through Friday deliveries between 8 a.m. and 5 o'clock. And that really helped, because our participation in our program in general, along with drug use in our county, has really increased over the last year. And so in last year, 72% of our interactions were actually deliveries, and 28% were people coming to our sites. Another way, I know that Chelsea Cheatham and Jessica Johnson are doing a presentation right now about vending machines and harm reduction vending machines. This is something that's pretty new to us. We just got the approval from our Board of Supervisors 2 weeks ago to launch this program as well. So we're calling it the Haven Project, which stands for Health Access Vending Network, and it also works as a safe haven for people to get supplies. And we're going to have them all over the county. We're having 4 installed in our wellness centers, our resource centers in each town, and they will have syringes, naloxone, fentanyl testing strips, condoms, pregnancy tests, emergency contraception, take-home HIV tests, PPE, and a variety of other public health items. We're extremely excited to get this launched, and big thanks to Track B and Nevada just for making this something that's a possibility. So just want to kind of close it out and then open it up to questions, but the program changes. Our syringe service program operates completely different than it did in the beginning. We started off by getting participant feedback, and that's what we had modeled our program after. But we found out that continuing and getting consistent feedback from our participants really tells us what's working and what's not, and it drives really what our program looks like and how it functions. And so with that, I'll end it and open it up to any sort of questions.